Okay, it's a true pleasure to have Dr. Sheryl Kingsberg with us today to discuss all things vaginismus. Dr. Kingsberg is a clinical psychologist and professor in the departments of reproductive biology, psychiatry, and urology at Case Western Reserve University School of Medicine and is the chief of the Division of Behavioral Medicine in the Department of OB/GYN at UH Cleveland Medical Center. She is past president of the International Society for the Study of Women's Sexual Health, which is also known as ISHWISH, as well as the Menopause Society, and is an active member in numerous other national and international organizations, including the APA, American Psychological Association, the American Society for Reproductive Medicine, and the Society for Sex Therapy and Research. So it's a true pleasure to have her with us today. We will be focusing exclusively on vaginismus, a women's health condition that doesn't get enough attention and is both physically and emotionally challenging for those who struggle with it. So thank you so much for being here today, Dr. Kingsberg. We're so happy to have you. Welcome.
Well, thank you, Marnie. I know it's been a journey to get me here. Thank goodness for virtual. And I really, I know you said we're exclusively talking about vaginismus. It deserves exclusive attention. So thank you for covering this topic.
Absolutely. Maybe we can start off just by defining vaginismus so our audience can know exactly what we'll be talking about today.
Sure. Many women don't even know the term vaginismus, and it doesn't roll off the tongue all that easily. But it really reflects the involuntary tightening of those pelvic floor or vaginal muscles that makes wanted penetration, whether it's for sexual activity or inserting a tampon or having a pelvic exam, impossible or very painful. So it really is the anxiety response. It's involuntary tightening. That's what vaginismus is. It doesn't have anything necessarily to do with the specific cause of it. It is the experience of the involuntary tightening. That is the concept of vaginismus. And I say that because there are some people in the field that say, well, vaginismus doesn't really exist because it's no longer in sort of the diagnostic criteria, but in fact, it is used in medicine, it is used in medical terminology, and it is irrespective of what caused it, it is the involuntary tightening.
And is that often a trauma response or is
it can be. It can be a response to trauma, but guess what? There are many women who have what we would call lifelong or primary vaginismus. They've not had any trauma. There is just the anticipation that penetration will be painful. And your brain acts just like if your hand was heading to a hot stove. Your hand reflexively is pulled back before you can consciously say, oh, I'm going to get a third-degree burn. I better move my hand away. The reflex is, uh-oh, danger. It tightens up and moves away. And that is exactly what those pelvic floor vaginal muscles do in the thought that there is danger. It might cause pain. So either there has been pain and now you've developed this anticipatory response, or there was always just the worry. I mean, think about young adolescent girls who are thinking, using a tampon, I don't know if it's, what's going to happen. And there is the anticipation and the muscles automatically tighten up. And guess what? So now you have a self-fulfilled prophecy because now either there's going to be no penetration because those muscles are clamped tight, or it is so tight that actually pushing something in will cause pain.
And are you seeing a lot more of it now? Are a lot more people talking about it? Are a lot more people coming forward with it? Or is it still,
Unfortunately, it's still a little bit more it's still more taboo than I would like. All of female sexual health is still taboo. So, but there is a little bit more public awareness, and that I think is helping in two ways. One is women themselves are seeing things on the internet and therefore are recognizing, oh, that's me. And I think clinicians a little bit are being trained a little bit more to assess, recognize, and refer.
Mm-hmm. And who's best to diagnose vaginismus? Would it be a general practitioner? Would it be a urogynecologist, a gynecologist, OBGYN?
Well, usually an OBGYN, urogynecologists are a subspecialty, and so I would hate to think that a woman has had to jump from person to person to person to get there to be diagnosed with vaginismus. If
Mhm.
a primary care clinician assessed it, I would be thrilled because that means they are actually asking or doing a pelvic exam when we see that a lot of GPs are not. But for the most part, it's an OBGYN who has either heard the patient ask for or complain about involuntary tightening, or they've gone to gynecologist after gynecologist unable to have a successful exam, and they finally get referred.
Mhm. And what are some common misconceptions about vaginismus and painful sex that might be holding women back from seeking
Sure.
treatment?
Marnie, let me add one more subspecialty that refers to me, which is pelvic floor physical therapy.
Hmm.
Um, there are times when gynecologists will refer their patients to pelvic floor physical therapy,
Hmm.
recognizing that there's pelvic floor dysfunction, but not necessarily always recognizing the psychological consequence or cause of it. And it's the pelvic floor physical therapists that know that we can work together, and that I can work on the behavior therapy and cognitive behavior therapy approach while they can work on pelvic floor dysfunction. So didn't want to ignore that incredibly important population of
Hmm.
specialists.
And
All
pelvic
right.
PTs are really also taking on a much more biopsychosocial approach than they ever have before,
Yes.
which is
And if they
wonderful.
want to run me out of business, I'd be more than happy to have them
Some of
take it
them
on.
even have CBT training now, which is
Yes, they
incredible.
do. I think pelvic floor physical therapists are an amazing, they have been a huge change to women's healthcare and have, I'm a big fan.
Absolutely. Yeah, it's become, people now know what they do as opposed to just being like, a pelvic PT does what? They're going to do what? Sorry?
Well,
So,
I still do have to do that too. I say, well, I think you really would benefit because I also refer to pelvic floor PT and I have to explain what it is. And, so we work on the anxiety component of just going to pelvic floor PT, but your specialty is amazing.
and what is the common age of onset, would you say, for vaginismus? I mean, I know it can, be at any age, but is it usually quite young, would you say?
Not quite young, because many teenagers are not even attempting penetration either with first sexual encounters with penetration, but sometimes just trying to use a tampon or going for their first GYN exam. So not usually younger than, say, 14, 15.
Hmm.
But oftentimes, so the age varies depending on whether it's primary, lifelong, at
Hmm.
which point they may get to me younger, or sometimes the cause is because of religious and cultural beliefs that have been so ingrained that sex is taboo and intercourse therefore is taboo until you get married when you're supposed to flip that switch right over and procreate. And
Hmm.
so I see many women coming in their 20s because they've had an unconsummated marriage and wanting to conceive. So I get those referrals either from reproductive endocrinologists, fertility experts, or women coming in on their own because they realize they really want to conceive. And then you have our postmenopausal population
Hmm.
who have what I would say is a secondary or acquired vaginismus because at menopause they've developed genitourinary syndrome of menopause, GSM. With the loss of estrogen, they lose that estrogen in their vulvovaginal tissues, causing thinning of the tissue, dryness, and that causes pain, and therefore often vaginismus.
Hmm. So, why is it so important to address vaginismus early, and what could happen if it's left untreated?
Well, women go years miserable with not being able to have wanted penetration if penetration is part of their sexual life.
Hmm.
It prevents them from getting good reproductive health care because so many women who have vaginismus are absolutely petrified to go to a gynecologist because they know in their heads, I'm not going to be able to tolerate a pelvic exam, so they don't go at all.
Hmm.
And there may be other medical conditions associated with their vulvovaginal health that therefore goes missed. So
Hmm.
many reasons why it is a problem to not address it as soon as you can identify what it is.
Right. And what are your thoughts on dilators? And do you have a go-to for women who've struggled with painful sex for years?
Well, my thoughts of dilators are they really have gone hand in hand in my cognitive behavior therapy and behavioral medicine practice. So I think they're amazing. They are one of my best tools
Mm-hmm.
for women treating vaginismus. Um, so the whole approach to treating vaginismus, by the way, can I just say that if there are medical conditions causing the underlying pain, if there is pain, that absolutely needs to be addressed. If you have vulvar vestibulitis, if you have genitourinary syndrome of menopause, um, then trying to do penetration when the tissue is not healthy isn't really going to be helpful. So being able to assess whether there is a medical condition that needs to be addressed, that should be taken care of, right? Uh, so I think that's really important. Like in sclerosis, for example, many women will have this pain, they don't know what it is, and they don't necessarily, and I would say, even if you can't tolerate a pelvic exam or a penetrative exam, a good gynecologist can take a look and see that there is something going on, be able to start that treatment. And then we can go to addressing the anticipatory anxiety that causes that pelvic floor tensing. So the dilators, and they come as static, meaning graduated sized, sort of dilators, or there is an expandable dilator called the Millie, and I have some examples.
Hmm.
Can be used to gradually expose and gradually teach. It's a conditioned response
Hmm.
that penetration need not be painful. And that is the whole goal, to have the woman back in control of her body and gradually, slowly help test out the theory that penetration does not need to be painful and can gradually insert and sometimes needing to stretch the vaginal tissue to allow for pain-free insertion.
And do you see a lot of success with the use of
Yes, it is. It's one of my favorite things to treat because success is huge. I mean, very rarely do people drop out of treatment,
Mhm.
and I'd say it's almost always successful.
That's great.
Yep.
How can using a dilator help those living with vaginismus regain confidence in their body and overcome fear of penetration?
Well, kind of like I said, it helps build up control. And, sometimes there's that fear that they can't control what's happening to their body. So the use of the dilators and practice
Hmm.
allows women to recognize that actually they are in control. They can make sure there is no pain. And I kind of anthropomorphize the vaginal muscles, if you will, by saying, the woman and her vaginal muscles need to be in sync, and she needs to kind of prove to those muscles that she can be trusted, that she will stay in control and make sure nothing bad happens and there will be no pain. And that is sometimes a slow, gradual, but very successful process. Okay. So think about what I'm going to show you some static dilators. Okay.
Okay.
These are just simple plastic dilators. Hold on. Um, Here's one. Okay. And it comes as kind of a set. There's a whole range of them. Okay. There's in this particular set, it comes as a much smaller one, but I don't have that one with me.
Okay.
It comes with a handle, which is nice. And it's hollow, it's plastic, easily, washable,
Hmm.
easy.
Hmm.
Nothing scary about it. They're kind of boring. They're not sexy, but they're but they're also not too intimidating. They're just simple plastic. And what's nice about the plastic is that you can put a lubricant on it so that it's slippery, can slide in.
Mhm.
Some people really like silicone ones. They're prettier, they're more flexible and soft, and those are very fine too. I happen to have the plastic ones right here. They're easy. Anyway, the whole idea is to gradually, as I struggle to get
Mhm.
to
On the
get it.
handle.
Okay.
There we go.
So anyway, there's the handle.
Yep.
Each one will slip on. And if you take this, my fist,
Mhm.
as the introitus of the vaginal opening, the whole idea is to gradually expose to dilators and penetration. Sometimes the first step, and it's a hierarchical approach, right? We build up a hierarchy of what creates anxiety and only move slowly to success with increasing sizes. But to start, sometimes I have women just look at the dilators
Mhm.
and have to get over the anxiety of, oh my God, you're what? What are these? And until they can not have, sort of racing heart rate at the mere sight of them, which by the way can happen,
Mhm.
then we start with getting into a lithotomy position, getting women used to, say, laying on their bed and on their back with their clothes off, right, from the waist down, and just get used to that, right? Even that can be anxiety producing for women who've had this fear of penetration. So once they can adjust and not feel anxiety just in that position, then we may then take the dilator, right? And all we're doing in the first few days is just have a woman touch the tip of the dilator to the tip of her vagina, to the introitus.
Mhm.
Because what she will then notice, because what I want is I want her to notice how those muscles automatically tighten up. They tighten up. They're like, again, back to that hand heading to a hot stove. They're like, what? See, I knew you couldn't be trusted. What are you going to do? And until you can have the touch and have the muscles relax in the presence of that dilator, we don't go to the next step, right? There
Mhm.
needs to be trust that develops and exposure, exposure, exposure. Once the muscles in the presence of the dilator can relax, then you might slip it in, say, an inch. And the same thing's going to happen. Those muscles are going to tighten up. There's going to, oh my God, see, I knew she couldn't be trusted. And if there is pain, you withdraw to where there's no pain. Okay,
Mhm.
because again, you have to be trusted. But if it's tight but not painful, there's just tightness, you can then just keep it there at the inch and let the muscle say, okay, nothing bad happening here. And the muscles can relax in the presence of that 1 inch. And day after day after day, we gradually increase. Again, no pain, allowed if there's discomfort, allow for tightness, let the muscles relax. Okay. And we don't move to any next step until there is confidence, right?
Mhm.
Mastery that that's been done. And once you're done with dilator number one, and I mean done meaning bored, you go
Mhm.
to dilator number two, at which point the same thing's going to happen again. You say, you look at this, and she's going to go, oh, well, one was easy, but two, whole new ball game, and we start all over again, just the touch. Again, it's the same process, slow and gradual building up control, confidence, and mastery. Now, when I show women this dilator, right, they're like, well, goodbye. But I want you to think about this process kind of like you would talk to a 5-year-old heading into kindergarten. Okay. If you told a 5-year-old heading into their first day of kindergarten, welcome to kindergarten. And by the way, by the time you graduate high school, you will have had about 100,000 hours of class, another 10,000 hours of homework, more. You will have learned, addition, subtraction, fractions, algebra, calculus, world history. A couple of that child would say, "See ya," right? That, but if you said, "Welcome to kindergarten. This first week, we're going to learn to color in the lines," right? That's that first dilator. And you don't build to the next until you've got mastery, and then it happens. And then it happens. Some women will do it very quickly, and they really sort of progress very quickly, and others may take several months.
Mhm.
And there's no, there's no, shame in taking time.
Mhm.
So when women will ask me, well, how long should it take? And I usually say, probably a little bit more than a month and less than a year. And then somewhere in between, it varies and it depends on your general sense of anxiety, because some women are more anxious than others, some are more sensitive than others. And it takes, it varies from person to person. My homework, by the way, a lot of times you'll read online, oh, you should be doing this 20 minutes a day.
Mhm.
No, because I will not get adherence to my homework if I tell somebody to do something that long. All I need is exposure, 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 and that means no more than 5 minutes a day. I want it to be part of their bedtime routine. I usually ask women if they floss, and hopefully they do.
Mhm.
And the idea is that you don't necessarily look forward to flossing, but you don't dread it either. I want it to just be part of your routine so that it becomes a nothing burger, if you will, and it allows for quiet time and no more than 5 minutes, so that you can do it more days than not. I would rather you do it 5 days a week for 2 to 3 minutes than 2 days a week for 20 minutes. That is not going to be my model. It's exposure, exposure, exposure with boredom as they gain control over their bodies.
Mhm. And how does Millie differ from the ones that you were showing us?
So that's a static dilator. Millie is really clever, and full disclosure, I've worked on its development and I am a consultant for them and working on their clinical trials.
Mhm.
But I think it's a fantastic invention, if you will. It is a technological advance in that while these are static and you have to go from, say, one size to the next to the next, and sometimes the jump is pretty high, the Millie allows you to expand 1 millimeter at a time, which is why it is called the Millie, because it expands 1 millimeter at a time to increase in size to be at its widest the same diameter as this large one.
Mhm.
So it does a few things. Number one, it's got a soft, flexible silicone cover, kind of pretty. And you can do it in two ways. I like the idea that you can insert at the narrowest, right? Because many women are really anxious about the initial insertion when they see a dilator, like, oh my God, how am I going to get that past my vaginal entrance?
Mhm.
This allows, again, the confidence and the mastery by inserting first, and then, as you can see, the buttons are plus and minus. You turn it on,
Mhm.
and there it is at 0. So this is at 0, and you press the button, and it will expand one. Whoops, I just went to 2 already. Can't really see it. 1 millimeter at a time. So she is in control. She can insert it. She's holding it and can expand under her control and have it expand while it is already inserted is so much easier. And then she can gain the mastery of having it inserted and then expand. And the other nice thing about Millie that the static dialer doesn't have is it has a vibration feature. So I'm going to
Mhm.
turn on the vibrator. It's got 2 speeds.
Mhm.
That's a little louder. Um, and while, many women say, well, it's not that sexy. I don't really, want to use it as a vibrator. It is not necessarily particularly used for sexual arousal, but what we have found, and we have a lot of feedback from women who've used Millie, is that the vibration helps the muscles relax. And so it kind of speeds up progress because the vibration actually allows the muscles to kind of relax in the presence of the vibration. So it expands again 1 millimeter at a time. I'm going to try and expand it as quickly as possible. And so you can do it in two ways. Again, you can insert narrow and
Mhm.
then have it expand, which is less anxiety producing. And then as women gain confidence, they can then expand it and insert, because when
Mhm.
women will say, well, great, I can insert and expand, but what happens when I want to have wanted penile penetration and my partner is not going to, be little and then grow? And they can again develop that mastery after that. So It is both to stretch the tissue, allow for mastery, and then progressive insertion at the larger sizes. So
Wow.
women
Yeah.
have lots of choices. This one is, and it doesn't jump from one graduated size to the next. It is, again, sort of a very millimeter incremental approach. So women like both.
Yeah.
This is a little bit more expensive, but for many women, well worth it, because I also like women, particularly postmenopausal women, to use dilators once they have succeeded in having, pain-free penetration.
Mhm.
I like the idea of using dilators intermittently to keep up that mastery, because again, let's just say you went several months before you had penetration again, the
Mhm.
anxiety starts to build up again. Uh-oh, what if I've gone backwards? Oh, what if? But if, once a week for 2 minutes, you've used your dilator or the Millie, you keep that confidence going again, right?
Mhm.
Muscle memory. So I think that dilators can be very useful to keep around for a long time.
Yeah. What an amazing little tool. I love how it just expands and it's just one,
Yep,
one
yep.
simple
One millimeter at
product.
a time, and
Yeah.
it allows for control so that you can also go backwards. So if you
Oh,
have it right, so it can't just go in one direction. So it will just press a
genius.
button and it'll go back. So that if you have inserted it, expanded it, and now you're anxious about withdrawing, you can again withdraw at this.
Lovely.
Yeah,
That's
very
great.
ingenious design.
I'll make sure I put a link so that people can purchase it. I'll make sure I put a link in the comment section.
Great.
So let's talk a little bit about anxiety and how it plays a role in vaginismus. I know you're an expert on this.
And vaginismus and anxiety are one. To
Yeah.
me, that is the key feature of vaginismus. It is the anxiety, anticipatory anxiety, that
Hmm.
creates the pelvic floor muscles to tighten. Okay.
Absolutely.
Otherwise, there are other things, genitourinary syndrome of menopause, that cause tissue damage or narrowing of the vagina, or some other vulvar condition, but it is the anxiety that is the vaginismus.
And what do you recommend to help break the anxiety pain cycle?
So that is
Dilators,
true for
obviously.
all pain. And I'm a cognitive behavioral psychologist, and so cognitive behavior therapy to me is my number one go-to treatment, and it is often the most common treatment and most effective for these kinds of pain syndromes, but particularly for vaginismus, because if you look at the cycle, right, if you've had pain, or even if you haven't, you just think that there might be pain with penetration, it creates anxiety. And with the anxiety, right, and there's tightening, you either have the actual experience of the pain, and then you create avoidance, right? Because why would you do something that hurts? And so that creates a catastrophic thinking. It's going to hurt, right? So the brain senses the message of penetration always hurts. And therefore, again, there's that avoidance. So we need to break into that cycle at some point. That's how we treat anxiety. And we alter the belief that there's no control, that penetration will always hurt, that it is, because now there isn't just, oh, it might hurt a little. It is catastrophic anxious thoughts of I'll tear, I'll cause irreparable damage. I will have the worst pain in my life, not just a one or a two, and it'll be a 9 or a 10. And so we have to alter that cognitively and then behaviorally, with that gradual exposure and paying attention to what's the worst that could happen, what is actually happening. Can you gain control and do some muscle relaxation, deep breathing exercises, some mindfulness of staying present. And as we gain that, mastery over the cognitions to recognize the catastrophic panic, and recognize the reality is she is in control and need not ever feel pain, that allows for changing that avoidance and then gradual exposure.
Hmm. It's
So
there's
it's
a
a,
lot. There's a
yeah,
lot. And
but
there's
it is a very common approach, cognitive behavior therapy, to alter the negative, anxious thoughts and
absolutely
then develop mastery.
yes. And how can we change the whole, it's so common, but so many women suffer in silence. How can we get more women talking about it and being more vocal and feeling less afraid to talk about it? And I know things are changing a little bit with social media and whatnot, but what can we do to sort of change the narrative here?
Well, on a broader scope, it is having conversations like this, saying the words out loud. A few years ago, I couldn't say vagina on television, and now, thankfully, we can. That was why genitourinary syndrome of menopause was changed from vulvovaginal atrophy, because, oh my goodness, can't say vagina. So, as you know, depending on how in the US things go, um, the idea that women's health is important, that women's sexual health is as valid and as important as men's, and that this is a common. Oh, we didn't we talked about how common it is and how much what the age range is, which is wide, but we didn't
Mhm.
talk the prevalence. At the lowest end of prevalence estimates, 5% of women. So that's millions of women. And at a higher end of some of the prevalence estimates, it's up to 17%. So it is not uncommon. It is very common. And women are all alone in it. They don't talk about it to each other. They don't talk about it with their mothers.
No.
And so opening that conversation is a way that we kind of get away from the stigma and the taboo and to not be ashamed that it is a common anxiety response and easily and effectively treated, right? If women are stuck thinking, oh my God, I have this and I don't know how to treat it, and doctors have left me alone, they're like, oh, go see somebody else or come back when you're ready to have a pelvic exam. I see lots of women who've been shamed by their clinician. As we train clinicians that this is a common thing, it is not just a uncooperative patient. I think on that end we need to teach our clinicians how to better approach women, sort of like trauma informed care. We need to meet women where they are and not rush them to have, a pelvic exam when they're anxious about it. So
Mm.
I think we work on it on both ends. We talk about it, talk about it, talk about it. We explain what it is, how to treat it, and we help clinicians be more comfortable talking about things. How many OBGYNs can talk about yeast infections and discharge, but they can't talk about sexuality. And so, we have not done a good enough job teaching our clinicians how to be comfortable with vaginal health.
And you knowing what goes on in the medical schools, are they getting enough education behind?
Absolutely not. No, they are not. And
This is,
ISWISH actually has done a scoping review of education in medical schools, nurse practitioner programs, PA programs, and midwife programs, which we will be publishing soon to show, what's the expected content in sexual health and what's actually happening. And unfortunately, it's woefully short in education.
that's really a problem that's coming up in pretty much all of women's health. Um,
Yeah,
Pelvic
yeah,
health is just, nothing is talked about enough. And anybody in medical school, you take a condition like interstitial cystitis, bladder pain syndrome, they tell us they spend maybe 20 minutes to 45 minutes on the topic, and then nobody wants to specialize in it. And then we have no doctors for a very large population of women struggling with a condition. So it's sort of, we're seeing this again and again. So
yeah.
clearly, we have a lot of headway to make here.
And a shared mission to create education, clinicians who are comfortable and willing to treat. And you think about many medical students as kind of nerdy. And so it's hard for them to talk about things like sexuality. So some of that is also an exposure model. We teach them language, how to have a communication, how to communicate better with women and not be ashamed or turn, to blush when they talk about anything that's related to sexuality. Women deserve good sexual health. It is a basic human right, and it is your healthcare clinician it's their responsibility to address it.
Absolutely. Well, thank you so much, Dr. Kingsbury. This has been really eye-opening, wonderful information. Thanks for coming on. I'm glad we finally got to make this happen.
I
And
know.
thank you, Millie, for sponsoring this today. And again, I'll put the link to purchase the Millie in the comment section. And again, that was just wonderful. And hopefully we can have another conversation again in the near future.
Well, now that you found me, Marnie, anytime. It was my
Okay,
pleasure. Thank you for having me.
sounds
And
great.
thank you.
Okay, talk
Bye.
again.